Welcome to Care Chats. Join palliative care experts sharing stories, information, and strategies. We're passionate. Join us, and let's get comfortable with palliative care.
Welcome back to Care Chats. We're excited to start a little mini series, a Care Chats 1.5 maybe season. We are hoping to provide some little short condensed episodes for you guys so you can learn a little bit more about palliative care in bite-sized pieces so that you guys, maybe even on your coffee break, can learn something about palliative care. So today we're going to talk a little bit about pain and how do we manage pain, and talk a little bit also about opioids. So if you're new to this, I am Brooklyn. I am a clinical nurse educator for a palliative care unit, and I am here with Jen. And do you want to introduce yourself, Jen?
Hi, I'm Jen. I am a consult nurse here at the U of A Hospital, but I also work casual on the palliative unit at the Great Ends. So we are both Covenant Health employees.
Awesome. Okay, so Jen, would you be able to tell us a little bit more about types of pain that people might experience?
There's actually three main types. So we'll start with the most common that we think of when we think of pain, which is nociceptive pain, and that's pain from tissue damage. So that's when our pain receptors are kind of activated and lit up, right? So there's two types of nociceptive pain. We have somatic, which originates in the bone or skin, muscles, joints. So kind of like if you have metastasis to the bone or you have a surgical wound, and that would count as somatic pain. And that feels usually more like aching or throbbing. And then the other type of nociceptive pain is visceral pain, which is pain to your internal organs. That sometimes gets described as cramping or deep or diffuse. So if you have pain from a bowel obstruction or liver capsule pain, that can count as visceral. The second type of pain is neuropathic pain. So that's from the somatosensory nervous system. So often feels like burning or shooting, shocks, tingling, numbness. When I talk to people, sometimes I describe it as sparky kind of pain. So examples of that could be compression of a nerve, for example, or things like chemotherapy can cause neuropathy as well. And then the third type of pain is called nociplastic pain. And I think this might be a newer classification of pain. It's not something I learned in school way in the olden days. But it's pain that has no clear physical cause. So one example might be fibromyalgia, and it might be influenced by psychosocial factors. And we'll talk a little bit more later on too about total pain, which might kind of tie in a little bit.
Typically, when we think of pain management, we often go to opioids. And it definitely is something that we use for pain management. And so maybe we'll talk about some side effects that can occur when we are administering opioids. One of them being nausea. This definitely occurs within the first few days if the dose is increased or we change to a different opioid. Our management for this is typically going to be an antiemetic. Maxaran is typically a choice that we use simply because it has dopamine antagonists and stimulates gut motility, which opioids induce nausea because they activate that chemoreceptor trigger zone in the brain, and it also decreases your gut motility. Another very common side effect is constipation, and this side effect will not resolve spontaneously. So if your patient is on opioids, they need to have bowel care of some kind. Our goal is typically for somebody to be having a good bowel movement every 2 to 3 days. Another very common symptom we see is somnolence or sedation, drowsiness. This again too is often temporary, only lasting a few days. So we will just monitor the patient. However, if there is ongoing sedation or drowsiness, then we might want to address some other causes that could be contributing to that. Dry mouth, also a common side effect. Again, we use good mouth care to help prevent any complications from not having good oral care and having that dry mouth. Some less common side effects of opioids would be pruritus or itching, urinary retention, and neurotoxicity, which we'll talk about in a little bit. And then last but not least, I think we do have to address respiratory depression. This definitely is a side effect that a lot of frontline staff and even families or patients might be concerned about, but I think it's important to recognize that the risk is extremely low of respiratory depression if we're starting at appropriate doses and we're titrating appropriately.
Brooklyn, I know you're talking about respiratory depression, but what do you think about this maybe myth that opioids can hasten death?
Yeah, and so as we're kind of just talking about these side effects, when opioids are titrated appropriately and prescribed appropriately, that risk of respiratory depression is quite rare. And so opioids do not hasten death, they just help somebody have a more comfortable death. And those side effects that we would often associate with, decreased level of consciousness and decreased respiratory rate are not because they're overdosing on the opioid, it is because they are passing away from their natural disease that they have. That kind of ties into another thing that we'll discuss, which is the difference between opioid overdose and neurotoxicity. So, your overdose is when you've had too much opioid and there's an acute change in the patient condition. So, this happens usually in a short time frame, and they'll have those pinpoint pupils, respiratory depression, decreased level of consciousness. And our treatment's going to depend on severity. If it's mild, sometimes it's just a matter of holding the next dose, but oftentimes this is reversed using naloxone or Narcan. Then we have toxicity, which is different than overdose, and this is the hyperexcitation of the nervous system from a buildup of byproducts from the opioids being metabolized. This risk is increased with renal impairment as the body cannot flush out the byproducts. So your symptoms of opioid toxicity are going to be myoclonus, which is twitching, hallucinating, vivid dreams or nightmares, hyperalgesia, which is an increased pain response to something that is mildly painful, or allodynia, which is a pain response to something that's normally not painful, such as like light touch. And our treatment for this is going to be fluids and or we reduce or rotate the opioid that the patient is on depending on the severity. And so we've talked a little bit about opioids, but should all pain be treated with opioids, Jen?
I would say it's a bit of a myth that all types of pain are to be treated with opioids. Like, really, when you're looking at pain management, it should involve what we call multimodal strategies, which means we want to use a bunch of strategies from different sources. So, opioids, sure, in specific situations, but also non-opioid medications like NSAIDs or steroids. How about things like physical therapy or psychological approaches? These can be tailored to the patient rather than just relying only on opioid use. And this will depend on the source and type of pain, of course. Not all pain experiences benefit from opioids, so chronic pain and total pain can be an example of this. Total pain's a bit more complicated, and maybe we can get into that in a later episode. But other interventions that can address pain that don't involve medication, particularly for cancer patients, as we might have noticed, can include things like radiation or a celiac plexus block, nerve blocks, vertebroplasty, or sometimes even surgery if the pain is from a broken bone. Sometimes the only way to fix it is by, fixing that broken bone. Should we talk about another myth?
Yeah.
If you aren't in pain right now, then you don't need pain medication, even if it's scheduled every 4 hours. So when you have a scheduled analgesic, it's often used to prevent pain from returning rather than waiting until it becomes severe. So it's really important to maintain consistent medication levels in order to avoid cycles of uncontrolled pain, and it might reduce the need for higher doses later. So what I often tell people is that we want to avoid that yo-yo. So we want to stay nice and consistent and steady.
For sure.
So what if a patient is moaning or grimacing and they can't talk to us or they're agitated at the end of life? Does it always mean they're in pain?
No, so that's a really good question. Oftentimes, those signs and symptoms, those nonverbal, I guess like nonverbal cues that someone might be in pain, that they're moaning, they're grimace, they're restless, they're agitated. We think that they're in pain when really they actually could be delirious. And delirium is very common at end of life. So, what happens if we only give opioids to treat that? We can actually make the delirium worse. So, one thing that we want to consider is if we're giving pain medications and they don't really seem to be working, we could try a medication to help with that anxiety or that restlessness and see if that helps settle them. And then maybe we are addressing both their pain and the delirium that they are potentially experiencing. And sometimes that moaning, especially at end of life, can just be air moving across the vocal cords. And so when we maybe think that someone's in pain because they're moaning at end of life, let's look at how they're also presenting. Do they have a furrowed brow? Do they have a clenched jaw? Or do they have increased respirate? Or are they very relaxed and their face is very neutral? In that case, they could just be having that vocal sound coming because of air going over their vocal cords, and that doesn't mean they're actually in pain.
The older nurses, when I was coming up in nursing, had described it as an expiratory moan, which is really just the patient kind of audibly sighing as they're exhaling.
Mm-hmm.
Thanks for joining us, everyone, for our little mini episode. Hope you enjoyed your coffee break with a little touch of palliative care. See you next time.
Bye.
Bye.